So, dear colleagues, dear friends, my name is Augusto D'Onofrio. I'm a cardiac surgeon at the University of Padova, Italy, and I'm gonna discuss today about the stroke rates with a single branch endovascular system for total endovascular aortic arch repair. We all know that the gold standard therapy for patients with aortic arch pathologies is open surgery with aortic arch replacement and reimplantation of supraortic vessel performed under cardiopulmonary bypass with deep or moderate hypothermic circulatory arrest and selective antegrade cerebral perfusion. The gold standard therapy of these patients is frozen elephant trunk. But this operation is demanding and is associated with a non-negligible rate of morbidity and mortality. And morbidity is mainly related to neurologic problems, and especially in high-risk patients. And recently, endovascular total arch repair with proximal landing zone in zone 0 and distal in zone 3 with branched stent grafts has been proposed as a therapeutic alternative to open surgery in inoperable or high-risk patients. This procedure allows an aortic arch repair with a micro-invasive approach, meaning that this procedure is performed off-pump with no need for aortic cross-clamp. The heart is always beating, blood flow to the brain is always maintained. The procedure can be carried out in a completely percutaneous fashion and also with no need for general anesthesia. Stroke rate after endovascular aortic valve repair is variable, ranging from 0 to 33%, so pretty high. And there are several reasons for this, mainly related to manipulation of supraortic vessel, embolization of atherosclerotic debris, and problems with inadvertent occlusion of supraortic vessels during the device implantation. So the aim of this study, multi-center prospective study, was to evaluate mid-term outcomes up to 3 years, including stroke rate of total endovascular aortic arch repair using a single branch off-the-shelf bimodular system. Study device is NEXUS aortic arch stent graft system. There is a device made of 2 modules, a main module with a branch for the brachiocephalic artery and the aortic arch, and the second module that is the ascending module that goes into the ascending aorta. The 2 modules are connected through a dock and a special interlocking system that prevents detachment. This is a CE-approved off-the-shelf device, and it comes into different sizes in order to fit the great majority of anatomies. The key deployment steps of this device are the positioning of the main module with the stent with the branch in the brachiocephalic artery. When the main module is open, and the most important aspect is to correctly orient the dock towards the ascending aorta in order to have smooth and correct implantation of the ascending module. That is the last phase of the procedure. We included 28 patients in this study. 18 patients were included in the feasibility clinical study and 10 patients in the compassionate use study. Indications were isolated aortic arch aneurysm in 17 patients, chronic aortic dissection in 6 patients, penetrating aortic ulcer in 1 patient, and 4 patients had a combination of these pathologies. Primary study endpoint was overall survival, and secondary endpoints were the incidence of procedure-related unplanned reintervention, stroke, and paraplegia, that are the main outcomes endpoints of this specific study that I'm presenting you today, and also the incidence of endoleaks. If you look at baseline data, it clearly appears that this is a high-risk population. Mean age was 72 years, and more than 50% of these patients already had cardiac surgery operation. And the ASA risk score more than 3 was present in more than 90% of patients. Overall mortality was 7%, 2 patients. None of these deaths were related to the device. Stroke rate at 30 days was 7%, one major stroke and one non-disabling stroke. And interestingly, we did not observe any stroke up to any other neurological problem up to 3-year follow-up. If we go a little bit more into the details of the two patients who suffered from stroke after the procedure, as I said before, the first stroke was non-disabling, and this occurred immediately after the procedure with a left vein stroke that developed in postoperative day 2. In this case, the bypass procedure, supra-aortic bypass procedure, was performed the same day of the NEXUS procedure. So actually it's difficult to say if this was related to the bypass procedure or to the device implantation. CT scan demonstrated an ischemic stroke on the left parietal region in the territory of the left common carotid, left subclavian artery bypass, distal from the NEXUS device. And for this reason, the committee decided that this event is unlikely related to the NEXUS device and probably related to the procedure. And this makes sense because it's unlikely that an embolic problem occurs in the left carotid artery, since the left carotid artery is ligated after the bypass procedure. So somehow this territory is protected from distal embolization. The second stroke is a disabling stroke. This patient was found unexpectedly unconscious in his bed during his stay in the ward. So the autopsy showed no evidence of problems to the supraortic vessels, but brain infarctions were found at autopsy. So the adverse event adjudicating committee decided that this stroke was probably related to the device and to the procedure itself. Overall survival at 1, 2, and 3 years was 89, 69, and 56% respectively. In particular, we observed 5 late mortalities, and none of these deaths were related to the device and to the procedure. So in conclusion, endovascular repair with the NEXUS aortic arch stent graft system can be performed with a good success rate and established result at 3 years follow-up. In particular, stroke rate is low, especially if compared to other series reported in the literature. And of course, further studies with more patients and a longer follow-up are needed to confirm this initial experience and to extend the indications to a wider range of patients. I would like to discuss a little bit the reasons for why we observe such a low stroke rate in this patient population. As I said before, the single branch design protects supraortic vessels because the left carotid artery is ligated, the left subclavian artery is plugged, and so the only way from where the embolic debris can go to the brain is through the brachiocephalic trunk. But immediately after the opening of the branch in the BCT, actually the brachiocephalic trunk is protected as well. So there is a very low chance that embolic debris can go to the brain with this specific design of the device. The other reason is that there is no carotid puncture, no retrograde manipulation of carotid arteries. And this is another good point that explains such a low rate of stroke in this patient, and also the procedure duration, because this procedure after an initial learning curve can be easily performed within 2 hours from the beginning to the end of the procedure. Another important aspect is that stroke has been shown to be related to the number of branches for supraortic vessel. In particular, in this study with branch in over stent graft, it clearly appears that stroke rate in the single branch device is 7.8, so similar to the one that we found with NEXUS. In the double branch configuration, it goes up to 33%, and in the triple branch configuration, the stroke rate is 42%. So it seems likely that the more branches are deployed in, the higher rate of stroke occurs. Of course, these are small numbers, larger experiences are needed, but all these reasons altogether may explain the good results of this device and this technology in terms of neurological outcomes. I would like to thank you for your attention and hope to see you soon again. Thank you.